Hello, everybody. Good afternoon. My name is Tamsin Rose, and I have the great pleasure of being your moderator for this session looking at digital health and innovation. We're starting this session with a poll, and the question we're asking you is, do you think that governments and regulators such as the EU are hindering or advancing innovation in digital health? We've had a few votes so far, and I'd love to see your views on this. About half of you who voted so far are saying that they think regulators are advancing things. The earlier sessions in this digital summit have identified how fast the COVID pandemic accelerated the trends to digital and how they were used with some of the challenges and the benefits. And we're going to be exploring that with the speakers that I've got on this panel. Your questions and comments are very welcome. Please use the chat function to put them in, and we'll be asking the Q&A at the end of the session after the presentations. So I'm going to leave this poll open for another few seconds. It's dropped slightly. You were 50%, now 42% think that regulators don't know. 35% saying they're advancing it. They're moving it forward, but there's still a quarter of the people responding think that they're blocking it, they're hindering it, that there are challenges that the regulators are putting in place. So given that we're focusing on innovation, how we can get that into use, that's something I think our next speakers will want to explore. So let me introduce the first speaker, and I'm delighted to introduce Marlies Wezenbeek, who's from the Centre for Interstitial Lung Disease at the Erasmus Medical Centre in the Netherlands. She's the chair of that centre, a national expert, and belongs to one of the European reference networks that precisely looks at how we provide innovation and data to improve patients' lives. She's also the chair of the ERS Group 12.01, which deals with interstitial lung disease. So let me ask you, Marlies, we want to understand how digital home resources can be used and in clinical trial management. Marlies, let me pass you the floor, and bear in mind our poll currently stands that a third of people don't know if EU or regulators are a good or bad thing. A third think they're a good thing for innovation and health, and a third think that they are bad. So clearly our audience is evenly split about whether regulators are doing a good job at getting innovation out or a bad job. Something to reflect on. Marlies, the floor is yours.
Thank you very much. And thank you also for the organization for this invitation, and congratulations on this great summit, because I've tremendously enjoyed the talk so far. And well, my slides are coming up. Yes, thanks. As I was already introduced, I'm a pulmonologist at the Erasmus MC, and these are my disclosures. And there's three topics I would like to touch on with you and share my experience in ILD. And that is actually, what do we want with, why do we need home-based measurements in trials? What have we learned so far? And what are the challenges we're facing, but also solutions? And let's start with the patient, how it all starts. This is a gentleman I see in clinic, a typical patient with IPF, 70 plus years old. He has oxygen, and he has this idiopathic pulmonary fibrosis that is a detrimental disease, progressive, increasing shortness of breath, and you see the median survival on the right in green of about 2 to 3 years. With antifibrotic drugs, this will improve maybe with 1 or 2 years, but still he's in desperate need for better medication and trials also. And what do we strive for in these trials? We want to improve how patients feel, how they function, and how they survive. And to capture the intervention's effects, we need endpoints that reflect these modalities. And what we use most in pulmonary medicine is obviously lung function, but also patient-reported outcomes, 6-minute walk tests, and in other trials, depending on what they research, other outcomes. And that results in study designs that look like this and probably familiar to you. This patient has to come in over 12 times in a year, and these are full days with lots of assessments. But if you would look critically at these assessments, I think only 6 visits of them would actually be needed in the hospital. The rest could be assessed at home, and with the current technologies, that must be feasible. And that would improve the burden for patients and also the access to studies, because many patients struggle with access to studies. They have to travel distances either because their rare diseases are treated in specialized centers, their countries are big, and usually trials are not in every hospital. In my case, patients often are also dependent on oxygen, which is a hassle. They have energy and breath limitations. They're hesitant to burden their families. 12 days off per year for a family member is a lot. And obviously, we have the COVID impact now. But besides improving this burden and access to care, I think it is also important, and it could bring important things to the design of trials. And if we go to the example of idiopathic pulmonary fibrosis, we have drugs now that improve the disease course. And here you see the disease course in an untreated patient. This patient loses about 200 mLs a year. If the patient is treated with the currently approved drugs, this is halved. So a new study is on top of this standard care, which means that if this drug is equally effective, the margin that we need to detect is 50 mLs, which is more or less around the measurement variability. So to power your trial with this effect size, you either need more patients or longer trials, which is very unattractive in a rare disease with a prognosis within 2 to 3 years. What you also could do is have more measurements, but we're not gonna make this patient come in every week to the clinic, because it was elegantly calculated that if you would measure this patient every week, you could actually reduce your sample size easily with to a quarter of the patients you would need, or shorten your trial with half. So here I think there is also a great benefit of home-based measurements. And there's more benefits, which are obvious, obviously, monitoring compliance. We heard about that, safety monitoring, and also, I think, registries where patients actually own and fill the data and fill registries. And I think in this way, we really can have meaningful collaboration with patients. And that brings us to what have we learned so far? And I think the ILD field really has progressed in the past years. Other fields have too, I have seen, but this is what at least my experiences comes from. And what we've used most is home-based spirometry, apps to capture patient-reported outcomes, wearables like accelerometers, video consultations, and obviously also the pulse oximetry. And it all started when we realized that home spirometry could actually give insight to the disease course. Here you see the course of a patient over a year, and detect changes, and was even correlated to survival at 2 years. And further research has been done validating these results and showing that it can reliably be measured at home and correlates well with in-hospital measures. And this is a system that we developed together with patients. And we heard that in other talks, the importance of starting off with the patients. It took us 3 rounds with about 40 patients to actually come to the tool that we have now, where the patient measures and records symptoms and lung function at home. It's sent to a platform. The patient gets alarms. We get alarms. And in this way, we can easily communicate. The patient doesn't forget things. We have a good sight on how things work. But we wondered, what is the impact if you have a deadly progressive disease on monitoring your disease? So we did a randomized controlled trial in patients with IPF, the group with home monitoring and the group with standard care. And what you see here, our primary endpoint was quality of life measured with an ILD-specific questionnaire, is that the trend was in the right direction, the blue bar on the left, but overall it remained unchanged. If you looked at the psychological domain, there was a meaningful change compared to the non-home monitoring group. And more importantly, this correlated also with patient experience, who were on general very positive. Almost all patients would recommend this to others, felt more in control, and felt better communication. We also showed that you could reliably measure the gray dots at home compared to the red dots in hospital measurements. But I have to be honest, This is another trial, and it's easy to say this one is done in the US and ours was in Europe, but they had different results. You see here a trial in 50 patients about feasibility, so not randomized, of a home spirometry at home, and they struggled with technical issues with variation in measurements. So I'll come back to that later. And this was a revolutionary trial, with a new drug in a group of progressive fibrotic patients choosing home spirometry as primary endpoint. Unfortunately, the primary endpoint failed due to analytical and technical measures. And you see here one of the examples, the implausible values of 32 liters of lung function, and also the fact that they had not pre-specified how to deal with missing data. This one outlier point at the right top determines the whole curve for the 5 points. There were supposed to be 24 points. So these are also issues we have to deal with. I'm going to skip this. We saw a lot about post-COVID home monitoring, but I think we learned to use pulse oximetry specifically well in this setting. And as I said, how a patient functions is also an important outcome measure, and we're searching for measures that we can actually use outside the hospital and still detect how a patient functions. So step counters have been trialed, and this German data on the left show that step counters correlated well with 6-minute walk test and were equally predictive of mortality at 2 years. Also, sit-to-stand tests have been tested in different studies and showed correlation with 6-minute walk test and could theoretically be performed well at home. And recently at the ATS, I think there was a very fancy collaboration between Stanford and Apple designing a 6-minute walk test at home via an Apple Watch. Not cheap, but I think very attractive for trial management. And this is another way, and I think also revolutionary, of incorporating home collected data in the process of research, but maybe also in clinical trials in future. Patients that presented for the first time in clinic were handed out a spirometry and a step counter to already start monitoring their disease course, because this could inform your diagnosis and also influence your decision making on what treatment to start. They would upload these things to a collaboration platform where both the second or the smaller hospital and the tertiary center could collaborate and see this data and also facilitate diagnosis. And what you would see is that already in this early peri-diagnostic phase, patients with IPF had a different and more progressive disease course than the other ones, guiding your diagnosis and also treatment decisions. And here you see examples. But what you also see in this example is that we struggled, especially with the step counters, with variability and compliance. And that brings me to the last part. What are the challenges? Obviously, monitoring your disease takes time, takes effort on the side of the patient. So how is the compliance if you want and request this from patients for a long time? And these are data from the INMARK study, a biomarker study with nintedanib, an antifibrotic, and it showed that even at a year, the adherence was still around 86%, which I think is very encouraging. We also have to take into account that with spirometry, there's daily variation. So we don't only have to instruct the patient on technical issues, but also on timing of their measurements. And these pictures I showed you before, but I think one of the explanations is if you give the patients feedback on how the loops are and how the quality of is, they are very well able after about a week to do well. So don't underestimate the patient, make them part of the process also of quality management. And another thing on quality management is that we're currently working on means with artificial intelligence to actually filter out these implausible values, these technical issues. And this was recently presented at ATS as well and is further work in progress. I showed the unfortunate trial with the primary endpoint that failed on the home monitoring, but was positive with the in-hospital measurements. And I think we need rules on how to deal with these implausible outliers, how to deal with missing values, because you see the effect on the top left was the pre-specified analysis. If they could have done differently, the trial results would have been better. So we're learning from all these trials. So I think there are many more challenges, and many of those are not specific only for research, but they're also for the daily home monitoring. What is the optimal frequency of measurements? What are the alarm settings? How to deal with it? Is it increasing access for trials for patients who are more remotely or have less access now, or is that actually not the case? I think there are many open ends, and I think there are exciting and beautiful roads ahead for research. And you see this beautiful road here, which nowadays is also digitally available to visit. So I think we really have to move in this direction. So in conclusion, digital home resources in clinical trial management, why do we want them? I think one of the few important things are at least that it allows for closer monitoring at a lower burden for patients. It reduces your trial size potentially because you get more measurements. It makes the patient really a partner in research. And I think it allowed, even in current COVID times now, to keep at least safety really closely monitored. And what have we learned? I think we learned a lot in the past time. Home-based spirometry and patient-reported outcome collection is very feasible as long as you use a system that patients actually like and can work with and helped to co-develop. We need much more data on other outcomes and how reliably we can use these. We also need more data on long term. And there are challenges, technical challenges, analytical challenges, outside trials, I think also legislational challenges. But I think most of those can be solved if we collaborate together with researchers, clinicians, and importantly, patients. And that's also what I would like to say. Thank you. Most importantly to the patients, because not only did they help to develop all these things, but it really only works if you're in this together. And if you want to learn more about patients' experiences, please scan this and you will get a short movie explaining how it works from a patient perspective. Thank you very much, and I look forward to the next talks.
Thank you very much, Marlies. Very interesting to see the different perspectives and different results of the trials. And I noted there the point you made at the end, the importance of working with patients to co-create both the apps and the process. Before I pass to our next speaker, we've got another poll that we'd like to ask questions, because now we want to know, in your opinion, is digital innovation responding to patients' needs? Now, in the session before, we heard about experiences where patients said they'd lost their material or it had broken, their device was no longer working. In this session, Marlies told us about patients who had difficulty using it and the different views on what it was going to do. So let's see what you're thinking. Is digital innovation responding to patients' needs? Well, so far with the votes coming in, 2/3 of you are saying, yes, there are gaps. We only have a very small proportion, so we've got 3% saying it's not responding to. Overall, the vast majority is saying yes, but. About 20% is saying yes, full alignment between patients' needs and the digital innovation. But 3/4 are saying it's a good start, but there's a way to go. And I think that's a great bridge to our next speaker. And I'm delighted to introduce Jim Hollingshead, who's the president of ResMed Sleep and Respiratory Care Business, which is an industry leader in digital health. And they're particularly the world leader in CPAP machines and masks. So, Jim, you're going to be talking to us a little bit about how digital health could drive value-based healthcare. Jim, the floor is yours.
Thank you, Tamsin. It's a great pleasure to be here with you all today, and I'm really enjoying all of the panels. I do want to talk at a sort of a high level about our vision for digital health and where we think we can go in driving value-based healthcare. And I just have a few slides I want to share with you to talk about that. We think that digital health has huge opportunity. I actually agree with the emerging results of the previous poll. I think we are helping patients, but I think we're really just at the beginning of where we can go. And so there's still gaps. There's still tremendous gaps. But the promise is enormous of what we can all do with digital health. And so I think there's a couple of ways I want to talk about that this morning. First, I think that as you look at the applications of digital health today and how they're emerging, there's a real opportunity just to improve the quality and efficiency of care when we start to deploy digital tools. So we can improve access to care and equity. We can definitely improve efficiency of care, the efficiency of providers and systems. We can improve quality and efficacy, and we can also improve safety through the use of digital tools. And those are all sort of in doing what we're doing today better on some dimensions using digital tools. But I think there's also an opportunity to drive value into the system and to really, in many ways, improve the overall provision of care and the overall outcomes of care. And we tend to talk about that as personalizing care. So we talk about this framework of P5, where we can do things with data that are predictive and preventative. We can personalize care. We can bring patients into care so that they participate, and then we can prove. We can actually use data to prove which interventions work and which interventions don't. And so I want to talk just a little bit about both of those. Just how we can use data to sort of improve the flow of care today, but also what's the promise for that over time as we continue to deploy digital tools. And so I have this chart. It animates a little bit to show how there's a virtuous circle, and it starts with patients who I absolutely agree with Dr. Wiesenbeck. I think patients are so important in participating in this, but it starts with patients and caregivers, healthcare professionals, physicians, provider organizations, and then with industry players like ResMed, who are building tools. And I'll just say, I think that there's an interesting thing going on now where the medical device sector is really well positioned to aid in this because devices are the things that will generate data. In our world, and for example, just in sleep apnea, we're in an interesting place where our therapy, a CPAP device, is now also our sensor. And so we're providing therapy through a device that ResMed has been building for 30 years in some way. But now that device can capture data from the patients and capture usage data, which we can then use to improve care in multiple ways. And so all of these players on the left have to contribute and participate in what we're trying to do to deploy tools. And the first bit is there are two primary uses for data. And the first one is that we can empower patients to manage their own care. So we can give views of therapy to patients themselves, and they can see what's going on in ways where they wouldn't. In some cases, patients would have to wait to talk to a physician or a nurse practitioner or somebody to see how their care is going. But through digital tools, we can actually give views of therapy to patients themselves, and they can self-manage, which is a much better experience for them and much more efficient for the healthcare system. And then on the HCP side, on the provider side, providers can streamline their own workflows and streamline the way they manage patients. So they can manage, again, if I think about the sleep case, providers can manage patients by exception because they can see how patients are using therapy, and they can look at which patients need more help, which patients don't need more help, and they can work accordingly. And that takes out multiple steps for providers, and so they can focus their care where it's best needed. And that's the kind of the first basic use of data tools, and that's improving access. Patients are getting coaching, for example, that they wouldn't necessarily be able to get. It's improving efficiencies, and it can often improve quality of care as well. So patients will get coaching or interventions using digital tools that they wouldn't get, and so the quality of care. We've proven the case in many instances in our CPAP business. And in our smart inhaler business, which is a company called Propara Health, that we improve adherence to therapy dramatically when we deploy tools, which is really, we want adherence because we want better outcomes. And so by using data tools, you can easily make that case and continue to learn. And that's the primary use of data. The secondary use of data is to begin to collect it. So we can take patient data, always preserving privacy, always preserving data security. It's a very high value for us. We can tie it to other sources by tokenizing data, making it de-identified, tie it to other sources. And then we can start to do things like really drive forward research on health economics and outcomes, for example. So we can really, one of the things that ResMed is working on right now is we're taking the very large data sets we have of CPAP therapy usage, which is in the billions of nights of data, which to me is just a mind-blowing number. I think the number now is 8.5 billion nights of de-identified CPAP usage data. Right? We can take that data and we can tokenize it, de-identify it, and then tie it to claims data. And so we can start to see the relationships between patients who are using CPAP therapy. We can see how adherence drives outcomes, and we can start to tie it to other chronic diseases, other respiratory diseases, cardiac diseases, and start to see the benefit and make the case for the benefit. And that's a huge step towards value-based care. And so we know, and on sort of the top half of this page, what we're doing is improving the flow of care, improving adherence to care, making care more efficient. But on the bottom half of this page, you really start to see the promise emerging and being able to take any interventions where we have usage data, have patient data, have patients participating, and start to understand which interventions not only improve outcomes, but actually make life better for patients and improve the economics of care. So the system can start to invest in the better interventions. It's very basic, really not doable in chronic disease without data, I would argue. And so all of the data we're gathering off of therapies and interventions is going to be useful for this. Just very quickly, so there's a feedback loop here. I'm going to just jump to the next slide because I know we're short on time. When we think about the P5 medicine play, really it all starts with the individual in the center. The patient is the center of all of this. But what we're trying to accomplish is we want to have data so we can predict what's going to happen. We can prevent. The main reason to predict something is so you can intervene and prevent the advancement of disease, prevent hospitalization, do things like that. We can personalize it. And so as we get more and more data and we see how patients behave on therapy, whether it's a CPAP device or a ventilator or a smart inhaler, what we can do is use that data to increasingly personalize care. When we see patterns of care, we can apply machine learning and AI tools to prompt patients in certain ways when we see consistent patterns. And that's a technique that will just get better over time. The more data we have, the more patients who are on any given therapy platform, whether it's in our space or in another medical device space, the use of machine learning, you can start to intervene almost with an N of 1, really personalized care. And then because you have all this data from the patient themselves and you can provide it back to them, it really allows the patient to participate in their own care, which I think is really critical. And so you have this virtuous cycle of prediction, prevention, personalization, and participation. And over time, you can prove the case for that. We can have enough information to prove that the patient's experience is better, therefore the patient is more adherent on therapy, and because they're more adherent, they're hospitalized less, or they exacerbate less often, or et cetera, by condition. The boxes on the outside of the slide are trying to convey the capabilities that are necessary. And you can see that this all requires not just a flow of data and raw data, but it requires the application of data analysis tools. So, and this is an area where our business has been building capabilities for some time, and I think across medtech now you're seeing a number of companies try to build the capability to do big data analytics and apply artificial intelligence and machine learning into their therapies. We're really, honestly, just at the beginning of this. So ResMed's been working on this now. We launched our first data-connected devices in August of 2014. So we're 7 years into that journey, and we're just doing the tip of the iceberg now with all the advances we've been able to make. So I think the promise is enormous, and the only way we're going to do this is we're going to have to work together. And so I'm just going to populate all the bullets on my slide and just talk about it. So what is it going to require? It's going to require companies like ResMed and other medtech players to continue to drive their own digital transformations and make these tools available. It definitely requires privacy. I mean, I think one of the most important things in all of this is that the patient's privacy is genuinely protected, but that the patients also trust that their privacy is being protected. And so it's really, really important for all of these tools to work that patients can trust that we're all using data in a way that keeps their private data private and is only applying patient therapy data, usage data in ways that will benefit the broad population and them as individuals. And then as our last speaker said, this is really about collaboration across that whole space. So we need key opinion leaders to collaborate. We need institutions to collaborate, and we need companies to collaborate because we're all on this journey together. We're all investing, and all of the stakeholders should be working together to produce the studies that we need and to advance and learn from each other because we're so early in the space. And then the final bullet on this page is about regulation, which was our first poll. And I have to say, I think regulators have an enormous challenge. Everybody, as we're in this new era of the use of digital tools and the use of artificial intelligence and machine learning, it's moving so quickly that for all of us, it's just a kind of a constant learning and experimentation period. And I think regulators have a really tough job to know how to do that. I think I'll say that I think, in answer to your poll, my view would be both and. Right? So I think regulation is sometimes helping and sometimes inhibiting, but it's understandable because there's just so much going on, and that's why I think we need to all work together to do this. And so I know I think I'm a minute over time, so I'll stop. But look forward to discussion.
Thanks very much, Jim. And as a reminder to everyone, please put your questions or your comments in the Q&A function that you'll find at the bottom of your screen, and we'll come to that section and have a chance to hear from your messages. We already have some questions coming in. Thank you very much. So now we have another question to ask you, because here now we want to discuss the issue of digital exclusion, because these wonderful things that we've been hearing about, the better outcomes, the patient involvement and engagement, etc., that is based on the fact that people actually have access to digital tools. And we know that across Europe, there are significant proportions of the population that do not have access, don't have functional literacy. So digital exclusion is a challenge we need to address. And the question we want to ask you is, can we ever effectively address digital exclusion? Is it possible to address that? And I remind people that it's very clear as we look at the millennial generation and younger how much digital natives are. They are grown up surrounded by digital tools, but they're not the people who are mostly in the hospitals in need of chronic care, condition and management tools, which tends to be the elder population. So there are issues there around generations, there are issues around access to infrastructure, rural communities. We've got issues around the money that it costs for some of these equipment. So can we effectively address it? And we have a very optimistic audience so far. 44% are saying, yeah, we can do this. We can address it. I'm impressed by that. I'm surprised. Perhaps I've changed things, because now a quarter of the people saying no, they don't know. And so far, 20% saying not sure. This is a key issue, because as we move forward, we've talked about clinical trials, we've talked about home settings, we've talked about how important it is to be able to use these tools, both to enhance the clinician-patient relationship and for patients to feel more in control and empowered and better adherence. So this is really critical. So we need to make sure that we're addressing it. And our next speaker is going to pick up on this. Kjell Hansen is both a asthma patient and asthma ambassador with the European Lung Foundation. He's also the chair of the European Lung Foundation and a member of the executive committee for ERS. In addition to that hat, you're also a researcher. So you look at things from a slightly different viewpoint, and you're interested in this whole area of social media, digital tools and collaboration. So this is really your ballpark. So let me pass the floor to you and ask, how do we address digital exclusion? Kjell, the floor is yours.
Yes, thank you so much, Tamsin. And now you make me quite sad that I only have 10 minutes, right, to convey all these points that I'm so eager to talk about. But I have a talk in a slide-free fashion, and it's organized in 4 parts then. So first, I would like to have some basic points about patients and digital health, and then to convey some information about digital health literacy. And then I would like to touch upon some issues related to pervasiveness of technology. And finally, I would like to show a video from one of our patient organization partners called Respiamo. So digital health is considered a way to improve quality and capacity, efficiency and access to healthcare services and information. And thus it also holds a potential to promote health and improve health equity. So for patients to address, to engage in their own healthcare, having access to healthcare services and handling health information in an appropriate way, that is a very complex task for many people. And where the complexity is further increased is with the replacement of in-person options sometimes with additional digital health options. So talking about digital health literacy, then we need to touch upon 2 points. So both health literacy and digital literacy. So health literacy is often associated with the challenges incorporated in finding, understanding, using, and appraising health information and health services. And it's also associated with a wide range of behavioral and health outcomes, where digital literacy is associated with individuals' ability to find, evaluate, and clearly communicate through digital platforms. So in order to develop a digital health literacy, you need opportunity and ability. So you need competences to use, understand digital technology, and this is often gained through experience of digital technology in other contexts. Then you need to feel safe and in control. So feeling safe and trusting the system is essential to gain a sense of security and control over data. And you need to feel motivated to engage with digital technologies. So the curiosity, the courage, the enjoyment, and the feeling of closeness and comfort as motivational factors for use. So some of the barriers then to digital health literacy, it might be that you don't have access to good digital infrastructures, such as computers, phones, phone data subscription services, internet subscription, and Wi-Fi networks. And sometimes also that services are not offered in some areas, and then not equal access to all services. So people with learning difficulties, with autism, with some mental health issues, they also have raised particular concerns about the sustainability of remote treatment for their needs. And some patients, they might need to assist other people when using these health technologies, and that again creates other issues. So while the barriers to digital health can be addressed through the opportunities and ability to engage through the sheer innovation in ease of use, the lowered cost of devices, the improved connectivity, and partly also through next opportunities for different new opportunities for different engagement through audio, through video, through text and translation options. So the issue of feeling safe and in control, it might be addressed partly through legislation and partly through institutional principles such as fairness, reliability, transparency, accountability, privacy, and security. And then finally, the issue of motivation might be addressed through inclusiveness and user-centeredness and the feeling of making a useful contribution. So finally, on pervasiveness of technology, then technology might still not be as important to many patients as personalized care. So clear concerns have been raised about some groups of people being left behind, and therefore digital options should not always be a default. So where, of course, we are also aware that some patient groups, they feel that they are not equally included and facilitated in systems. And these groups might also be at risk of further marginalization. And then there are also some evidence to suggest new exclusions. And that could also be young people who might be comfortable with the technology, but might not want to use it in interaction with certain authorities. Then finally, there are some issues of fear and ethical considerations. So people taking care of other people might be concerned about creating digital footprints on other people's behalf. So on behalf of children, elderly, and so on, because these issues have implications that might go well beyond what we are capable of foreseeing. And then people don't ask questions or don't usually ask questions to understand the importance of ethics and unregulated data because it's not convenient to do so. Few do, but a majority don't. So we need to address this risk and concerns through outreach, through caring and designing for inclusivity, and by making critical dialogue about ethics and norm. Furthermore, we need to keep our awareness about the non-represented in the existing data sets. So with this, I would like to acknowledge our network of patients and patient organizations who have contributed valuable information and insights, which has been used in this presentation. And now I'm very pleased to introduce a video by our partner organization, Respiriamo, on overcoming patient barriers to digital health. So thank you.
L'esperienza dell'associazione Respiriamo Insieme è quella di avere spesso, frequentemente richieste da parte dei pazienti, dei soci, di avere informazioni e formazione per gestire la propria patologia, e quindi l'associazione da tempo organizza numerosi corsi rivolti al paziente con patologia respiratoria nello specifico, per avviare, dare strumenti informativi e formativi ed educazionali per saper gestire la propria patologia. Questo è stato proprio un grosso problema, il fatto che una grande fetta dei nostri pazienti, dei nostri soci, non avevano abilità nel digitale, e è stato questa diciamo così, la spinta a pensare al progetto di digitalizzazione.
Durante il lockdown ho sofferto molto, perché mi sentivo sola, non potevo contattare il mio medico, non potevo vedere i miei familiari per evitare il contagio. Imparando il PC avrò più possibilità di tenermi in contatto con il mio medico, essere più attiva nel gestire la mia malattia respiratoria e relazionarmi con i miei familiari.
Per i pazienti tutti, come me, come tanti altri, da casa, con l'opportunità del computer, poter gestire tutte le fasi della patologia.
Per questa ragione abbiamo deciso di avere 3 livelli di formazione. Il base, che è rivolto a persone che non hanno alcuna esperienza, a cui li prendiamo proprio dalla spina elettrica e li portiamo fino alla connessione via internet e alla partecipazione a meeting online. L'intermedio, rivolto a quelli che hanno già partecipato al corso base o hanno la dimestichezza informatica sufficiente, e l'avanzato. Durante il corso sarà presente sempre un pneumologo e una psicologa per dare informazioni e supporto alle difficoltà che incontrano i pazienti nella vita quotidiana.
Sicuramente il Covid ha dato una grande spinta al digitale, e credo che noi come associazione terremo tutto il buono di questa pandemia. Promuoveremo e incrementeremo attività digitali e il nostro affiancamento ai pazienti in queste attività, e crediamo che, come sempre è, conoscere il problema aiuta a risolverlo. Anche in questo senso, aiutare i pazienti a conoscere il digitale e a capire quali sono i benefici anche rispetto alla gestione della propria patologia farà sì che i pazienti sempre più si rivolgeranno a questo strumento per potersi curare meglio.
È bellissimo questa cosa che fa l'associazione. Grazie.
Thank you very much, Kiel, for sharing that, and particularly the video from that patient organisation, enthusiastically explaining how they've embraced digital and recognising that they needed to support the digital skills of the patients in order to allow them to engage with the digital tools that were available to support them. We're now going to move to the final speaker on our panel, and I'm delighted to introduce Michiel Strubin, who is the Director for Digital Health at MedTech Europe, which is the European Trade Association for the medical technology industry, and that covers both diagnostics, medical devices, and digital health. And you're going to be giving us some insight into how we use data in digital health, because of course we talked about the huge amount of data points. We heard from Jim, 8.5 billion nights of CPAP data. But what do we do with it? How do we turn data into health? Michael, the floor is yours. I think you're on mute, Michael.
Whoops, yes. I brought a few slides here. Thank you so much, Tamsin. I brought a few slides here, and I hope they're going to be put on screen very soon. I'm going to, I think we should address many of the issues that Kiel just talked about in the discussion here. I hope to bring some comments back to this. But let's look here. What I would like to talk about is going back perhaps to the initial conversation about whether regulators have a role in driving digital health forward. I would reply with an enthusiastic yes, but, and I would like to highlight some of the policy initiatives that are happening to improve data use here, because sometimes you rightly point out we have a lot of data points, but very often this data is locked in silos and cannot be made available for research and for improving patient care. So about 2 years ago, when the von der Leyen Commission started working on, one of their core issues they wanted to talk about and address is digitalization. And just barely 3 months into the reign of the Commission, a European health data plan, the data strategy for Europe was adopted. And I have you on slide here, the Commissioner for the Single Market, the Internal Market, Thierry Breton, saying, turning this almost into a patriotic or at least a sovereignty issue. We need to make better use of data. He also said, and so even in a tweet, he said, this is something that where we need to assert our sovereignty. I think in some of the official publications and pronouncements, he was a little bit more subdued. We need to access high quality data and create value for Europeans. And I really would like to remind us that this was really at the core of this European strategy. So this was a horizontal strategy. The Commission really wanted to advance this, and they wanted to do this in a number of different sectoral data spaces, but health was very much front and center. In fact, it was probably, this is not an alphabetical list, it was probably very much on the top of the minds of the European policymakers. And advancing a little bit further, the Health Commissioner received in her mission letter, Stella Kyriakides, who many of you may know, received as a to-do item to create a European health data space that supports research, health data exchange, and research on new preventative strategies. And she was asked to square the circle and also say, at the same time, you should ensure citizens have control over their own personal data. And of course, that kind of strikes close to the nub of our issue in Europe, because as we probably can all agree in the abstract, data-driven healthcare has a lot of promises for us. We can advance quality. We can guarantee the effectiveness of care. We can improve access to many people, and I'm keenly aware of the issues that Kiel cited in terms of digital literacy among marginalized groups. But for the overall number of patients, this can really improve dramatically their access. Think about the people in remote areas that live in underserved regions. Data can also improve the efficiency. Jim made the point about value-based healthcare. There is so much richness in data. It can tell us what treatments work and what treatments do not. It can turn the art of science, the art of medicine, into a science, into an evidence-driven science, into a data-driven science, so that we know more about, have more evidence, have more intelligence on what works and what does not. The pandemic that we've just come out of slowly, and I think I'm just realizing I'm haven't advanced yet my slide yet. The pandemic has, of course, taught us also that data is not necessary. There is still a lot of work to do on data and on achieving this type of data-driven healthcare. We've seen that data still gets transmitted via faxes, via paper, and that slows down the transmission of data dramatically. But the pandemic has also taught us how much data solutions can actually advance our quality of life. Think about the apps that tell us whether we've been in proximity to other people that carry the disease, and can tell us afterwards and notify us afterwards that they've had COVID, and so we should probably take a test. And we have, and I'm going to share the citation for this, a recent case study on the value of diagnostic information in acute respiratory infections that was created with colleagues from the ERS involved. Let's go back to the potential of data-driven, of AI in healthcare. We've done a study recently where our colleagues at Deloitte have calculated that the introduction of AI in healthcare can bring enormous benefits to European healthcare systems. There is the potential of saving lives. Every year we could save the equivalent of a medium-sized European city. We could realize so much savings, and could probably turn these savings amount to about 12% of total European healthcare expenditures, and we could free up healthcare professionals. And nobody is saying we should just get rid of 500,000 healthcare professionals in Europe. No, we can actually bring them to better use. For example, spend more time on those marginalized groups that Kjeld mentioned earlier. But of course, all of this requires a lot of work. We need to address a lot of barriers, and this is a slide that I borrowed from the European Commission, and I'm not going to read all of them to you, but this, of course, this is a list of all of the challenges that we need to address. We need to ensure, of course, control of patients over their data. We need to improve access of data for research and policy making. We need to break down some barriers for the single market for digital health services, and we need to smoothen the introduction of healthcare. One of the key issues that are plaguing us is the uneven application of the GDPR. In theory, and if we want to take the GDPR to the extreme, we need to ask every single patient for their consent, whether they allow additional research to be done on their data. That is not practical. A more harmonized way of agreeing on under what kind of conditions we could share data, make data available for research would be very much needed. So in conclusion, and this is my last slide, we need to tackle, I think, the European health data space with 6 interrelated issues, and we need to advance, I think, trust, which is at the core, I think, of what we need need to do. Trust among healthcare professionals, patients, and all citizens. We need to, of course, align EU and national and regional initiatives. If there is no health data space in the region, in the European regions, then we can't aggregate the data in Europe. We need to get to an aligned and harmonized interpretation and application for the GDPR. We need to, of course, improve interoperability and standardization. Cybersecurity is a huge issue. And finally, we need to advance digital literacy for healthcare professionals. And I should say here, among the patients as well. We are not trying to exclude patients. This is an oversight and will be fixed in the final slides. And with that, I'd like to close here. And sorry for being a little bit over time.
Thank you very much, Michael. And yes, to remind the audience that all the slides that we use, the PowerPoints, will be made available for you so you can download them and use them. And Michael will tweak his last one to make sure patients are on the page as they should be. We now have a very brief opportunity for some exchange with the panel. We've had some questions that have already come in, and I'm going to invite our panel members to have a look at them. But I think that there's two questions that have come up that very much link into the theme that's run through a lot of this, which is about trust. Somebody has said, who is going to monitor the artificial intelligence? And has made a reference to a newspaper headline from the UK that NHS patient data is going to be sold to a healthcare company. And really, are we right to be focusing on this issue of privacy and data protection? I think I'm going to come to you, Kjell, to pick up on this one. Who's monitoring the AI? And, anyone from the panel might like to pick up on this issue of how do we ensure both that researchers can use data so we can generate the outcomes that we need. And Michael, you talked about the fact that if you apply the GDPR at its most extreme, you have to have permission for absolutely every use you want to have, which blocks research. So finding the right balance on data protection, I think, is important. But Kjell, the concern about AI, it's not the first time I've heard it. It's very real. And I'm a science fiction fan. I read a lot of these things about AI gone wrong. So how do we monitor that?
Yeah, so thank you for the question. So I think in my talk, I talked about two things. So both that we have a proper legislation in place and we have trust in our institutions. So I think these two things at least are key in doing so. And then, of course, there's still a lot of discussions to be had about AI, how algorithms are constructed and so on, how they fit into the society and so on and so forth. And I think it's very important that we need to articulate and have these discussions also both in the academic and the public arena.
Okay, thank you. Who from the panel might like to pick up on the importance of, finding this balance between data protection and privacy for patients, but then also having the data accessible for researchers so we can generate the response? Who'd like to pick up on that?
I'll comment on that.
Lovely, thank you.
As I said in my comments, I think it's absolutely critical that patients trust that their data will be private. Even if it, no matter how it's going to be used, I think they need to trust that their data will be, kept private. And from our point of view, the patient owns their own data, right? And so they need to give permission, they need to know how it's going to be used, and they need to give permission for that. Now, regulatory layers on top of that can sometimes make it quite difficult, but I think that, all of the stakeholders in the system who are going to use data need to be transparent about how they intend to use data. And then it's up to the patient if they want their data to be included. And we'll only have enough data if patients have confidence that we're going to treat it with privacy. It's something we're very obsessive about, the tools we put in place to make sure we're maintaining privacy for patients, and we're obsessive about being transparent about how we're going to use it. And our general principle is we're only ever going to use patient data to benefit patients, not to do other things with it that are unannounced or somehow kind of kept in the dark. To us, it's both of those things together. It's using the data for benefit only, being transparent about how we intend to use it, and making sure that patients actually can decide how their data is used.
And if I may, actually the the medical device industry is actually tightly regulated, just picking up on Jim's point here. There are tight regulations in Europe and in other parts of the world that really govern under what circumstances and for what purposes we can gather data. And still, the GDPR sometimes inhibits us from aggregating data, particularly when it comes to patients from different jurisdictions, different regions, where GDPR is differently applied. And that is probably something that we as an industry hope will be addressed in the European health data space legislation that is coming up later this year or early next.
Thank you. I'm aware we're coming to the end of our time, and I just want to know that this hot topic of how we balance out the need for data to flow in the system, for us to allow, as you know, Michael, you said, for the medicine to move from art to a science, because it's evidence-based on data, and then ensuring we have patient trust. We'll be covering that a little bit more tomorrow in the session on ethics, and we'll have speakers on that. In our last minute, can I invite each of our speakers to just say a few words about the importance of innovation? Because we talked at the beginning about how the pandemic drove people onto digital. And that was a sort of a reaction. Whereas if we're talking about innovation, it's about leading and seeing where this will take us. And at the beginning, when we asked people, do you think the regulators are leading, supporting, or hindering, or you don't know, we were split evenly, the audience. A third said, yes, it's supportive. A third said, no, it's blocking. The third said, not sure. So in this area of innovation, I'd just like to have one sentence from each of you to see where we're going in digital health. Where is the innovation leading us? And maybe we'll go in the order we went. So Marlies, briefly.
I think it will allow much more meaningful collaboration between patients and doctors and other stakeholders, because also for this consent, patients, you can make it much more dynamic. So I think collaboration is where it leads.
Fantastic. Jim?
In our world where we have billions of people, we have fewer physicians, we have less access to care, and we have compressed government budgets and payer budgets, innovation is the only way to bridge the gap, right? So we're going to have to use digital tools to be able to provide care. It's really not optional. And so we all have to work together to continue to push for the use of the tools that have changed really all of our lives in other settings to change.
Thank you. Kjeld?
Yeah, so I agree very much with my co-speakers here. So I think there are two things that we need to focus on. We need to keep focus on the patient in the center, and then we need to collaborate across the different spaces and competences.
Lovely. Thank you. Michael?
Final thing, perhaps, digitalization means empowerment. Think of the back ages when we didn't have the internet, when we didn't have access to information. Today, we have devices that can actually tell us what your step count is, what your well-being is. We are empowered to make better decisions about our lives.
Fantastic. Can I say a very warm thank you to the members of our panel? It's been a really interesting conversation exploring the interactions between innovation and digital and patient empowerment. And I leave you with this message that collaboration will be key. And building on the previous panel, it was about trust, collaboration, and putting patients in the center, because there is no alternative. So warm thank you to all of you. We'll take a short 2 or 3 minute break, and then we'll start again our final session, which will wrap up the conversation from today. Thank you again to our speakers from this panel.